Hello everybody, my name is Dr. Bear and I am endocrinology lecturer at University of The Hague. Today we will talk about a topic in thyroid gland, and specifically I will give a short talk about thyroid nodules. As we all know, thyroid nodules are very common and the prevalence may be as high as 5% on palpation. However, the prevalence is 67% on ultrasound. And that's why every now and then we will have cases of thyroid nodule which are detected incidentally. So during my short talk, I will try to give the key messages how to evaluate these nodules in the best way. It's an update about thyroid nodule, and this is a very common topic. Important facts about thyroid nodules: lifetime risk of developing a palpable thyroid nodules is approximately 5 to 10% of the population. And here we mean by this female gender. However, malignancy of the thyroid occurs only in 0.004%. It means it is not so common. What does it mean? Roughly 5% of the thyroid nodules are malignant. Of these, well-differentiated thyroid cancer accounts for 85 to 90%. So thyroid nodules are very common. However, not every nodule is cancer. And that's why we have to pick up very precisely which nodules should undergo more evaluation. So lifetime risk for male gender to get a palpable thyroid nodule is only 1%. So it is not very common in male. However, if a male develops a thyroid nodule, it's very risky to be malignant, and gender difference is important. So once male have a thyroid nodule, we need to take it more seriously. Now, thyroid nodules, are we going to talk about an epidemic? We have many emerging articles naming that the increase in the incidence of the nodular cancer as epidemic, as in New England Journal of Medicine, and in other journals like here mention managing an epidemic. And here mentioning thyroid cancer epidemic, is it an alarm or what's going on? So my question here is this epidemic real, or we are over-diagnosing thyroid cancer because we are over-investigating thyroid nodules? To answer this question, we are just seeing the tip of the iceberg if we will follow the Korean experience. Now, when they adopt the thyroid screening program, the thyroid incidence of papillary cancer increased abruptly, and the thyroid cancer mortality remained fixed. So the question here is, in this screening, we overdiagnose the unnecessarily thyroid foci of thyroid cancer, and we did the operation which were not necessary because the mortality remained fixed. Now, the tumor being excised are getting smaller. At one center, the proportion of the patients undergoing surgery for a tumor measuring less than 1 centimeter in diameter increased from 14% in 1995 to 56% 10 years later. It has been estimated that at least 1/3 of the adults harbor small papillary thyroid cancers, the vast majority of which will not produce symptoms during a person's lifetime. So the experience with the thyroid cancer screening in South Korea should serve as a cautionary tale for the rest of the world. Now, prevalence of the thyroid nodules. How common is this scenario, thyroid nodule? It depends what method you use to detect them. If it is by palpation, as we said, in female it's 5% and in male it's 1%. If you use autopsy, then after autopsy it is 50%. However, if you use sonography to detect thyroid nodule, the incidence will be increased to 67% because of the good quality machine. That's why we will have an epidemic if we screen all people by an ultrasound of the thyroid gland. So the question here is evaluation of the thyroid nodules. What is the best way to evaluate thyroid nodules? And here, to answer this question, here we will depend on the ATA guidelines 2015 to answer this question. Thyroid ultrasound and fine needle aspiration are cornerstones for evaluation of the thyroid nodules. Now, sonography features of the benign nodules, how it looks benign nodule. We will have macrocalcifications, hyperechogenicity, peripheral vascularity, no lymph nodes, smooth contour, homogeneous texture, wider than deeper in cross-section. And this is a typical picture of the thyroid nodule, which is benign. And we see how the borders are smooth and how everything looks benign. While in comparison to the malignant nodules, we will have features like microcalcifications, hypoechogenicity, increased intranodal blood flow, and altered lymph nodes, irregular contour, incomplete margins, subcapsular location, and deeper than wider in cross-section. And here are a variety of these features appearing in these pictures, like microcalcifications and how the hypoechogenicity and how irregular borders and all features which may indicate that this could be a malignant nodule. Now, high suspicion pattern of malignancy carries a risk of 70 to 90% that could be malignant. Look here, we have microcalcifications, and here we have irregular borders, and here how it looks taller than wider in cross-section and other features. Remember, microcalcifications, specificity for diagnosing cancer is 85.8% to 95%. And here, solid hypoechoic nodules or solid hypoechoic component of a partially cystic nodules with one or more of the following features carries high risk of malignancy: irregular margins, microcalcifications, taller than wider in shape, and rim calcifications, and evidence of extrathyroidal extension. Now, if you have high and intermediate suspicion lesion, then which is solid hypoechoic nodule with one features, or solid hypoechoic with no features, this is called high and intermediate risk or suspicion, then the risk of malignancy is high actually, and 70 to 90% in high risk suspicion, and intermediate 10 to 20%. Now, in these cases, in high and intermediate suspicion, nodule fine needle aspiration biopsy is indicated. When nodule is more than 1 cm, we have to evaluate by biopsy. While in low suspicion, like isoechoic or hyperechoic solid nodule, the risk is just 5 to 10% of malignancy, and here we recommend fine needle aspiration biopsy when size is more than 1.5 cm. Now, in very low risk, which carries less than 3% risk of the malignancy, like spongiform form, here we recommend the biopsy only when the size is more than 2 cm. While in purely cystic nodule, fine needle aspiration is not indicated actually. Now, my conclusion and recommendations for this short and brief talk: the majority of the thyroid nodules are small, non-palpable, benign lesions that will never become clinically significant over time. Neck ultrasound combined with fine needle aspiration biopsy plays a key role in the distinguishing the low and high risk nodule subsets. And I will finish my talk by this quote from Thomas Hoxell, who said, "The deepest sin against the human mind is to believe things without evidence." I mean, here we have to wait more data regarding the etiology of the thyroid nodules and what is the best way to evaluate these nodules so that you avoid epidemic and at the same time you don't miss important cases of early diagnosis of thyroid cancer. And thank you very much for your attention.